Super. Thanks for that, John, and for so expertly moderating that session. I think that really whet everyone's appetite for what it is we're going to be talking about. So now we can go into a little bit more of the technical detail. So this session is going to be on epidemiological study designs. How can they guide evidence-based interventions against zoonotic disease outbreaks? And I'd like to just give a brief intro to our chair. So we've got Dr. Yewande Alimi, and she's the AMR and One Health Program Coordinator at Africa CDC and co-lead for the African Union Task Force on AMR. Dr. Alimi currently leads the implementation of the AU framework for AMR control in the AU member states. She also leads the implementation of the Africa CDC framework for One Health practice in NPHIs. Drawing on a range of experience that includes veterinary medicine and public health policy and research. He leads on Africa CDC's One Health activities, development and implementation of their One Health programs within Africa CDC and across its member states. So we're really pleased that Dr. Alimi can join us to chair this next session. So over to you, Wande.
Thank you very much, Dr. Osmanda. It's a pleasure to join the team here today. So participants, I will be chairing this exciting session. Like Dr. Das rightly said, I will be focusing on epidemiological study designs and how they can guide guidance-based interventions against zoonotic diseases outbreak. For this session, I have 3 speakers, and they will have 10 minutes each to walk us through key areas of their expertise. Participants, like the previous session, we will have the Q&A discussion right after their presentations. If you look at the bottom of your screen, next to the interpretation button or the raise hand function, you'd see a Q&A tab there. Please feel free to put your questions there, and I will be sure that the experts at least answer some of them. I'd like to welcome Dr. Marietjie Venter. Professor Venter heads the zoonotic, arbo, and respiratory virus program in the Center for Viral Zoonoses, the Department of Medical Virology, University of Pretoria. She has over 15 years experience in One Health investigations in the field. She's also a member of the WHO Technical Advisory Group on Arboviruses and chairs the Scientific Advisory Group on the origin of novel pathogens. Dr. Venter, it's a pleasure to see you once again. The floor is yours for your presentation.
Okay, so thank you very much for the invitation. I really appreciate it. So I'm going to take you through some issues on arboviruses. So the purpose is really to consider some epidemiological considerations when investigating vector-borne viruses in Africa. Okay, so just a brief introduction. So zoonotic arboviruses fall into 3 main families and only a few genuses. So there's a couple of very important arboviruses that's present in Africa, and I'm only going to focus on them, although there's many others that's not included here. So the main ones in the alphavirus genus is chikungunya and probably Synbis virus. And these 2 viruses differ in the fact that they are transmitted by Aedes mosquitoes and Culex mosquitoes respectively, but both of them are associated with polyarthritis and rash. The Flaviviridae and flaviviruses are some of the most important arboviruses, and here we think of Zika virus, West Nile yellow fever, and dengue, which are all present in Africa and actually have emerged from here to many other countries. Here also, West Nile is transmitted by Culex mosquitoes, while the others are transmitted by Aedes mosquitoes. West Nile and Zika is associated with acute fever and rash, and then can also cause neurological signs, while yellow fever and dengue can cause hemorrhagic fever signs. And then in the Bunia viralis, Rift Valley fever is a very important virus transmitted by Aedes mosquitoes and can cause retinitis, encephalitis, and hemorrhagic fever signs, while Crimean Congo is the only one that's transmitted by ticks here and can cause hemorrhagic fevers and is found across the continent, but I'm not going to speak further about that one. Okay, so the typical arbovirus symptoms can be very non-specific. So if you do surveillance, it's important to be able to to detect these amongst many other common viruses or common diseases, and which is also the reason that sometimes it can be missed. So in humans, most cases will have a fever, a headache, myalgia, arthralgia, morbilliform rash, and conjunctivitis. And then some of them you'll get complications such as encephalitis in the case of West Nile, as well as paralysis, and then hemorrhagic fever and death for yellow fever and CCHF, for example, and Rift Valley fever. In animals, it can also be a mild disease, but in some of them, there's more severe disease, such as Rift Valley fever can cause abortions, encephalitis, and paralysis in certain animals, such as horses with West Nile. And this is possible then to trace these outbreaks by looking at these severe symptoms or syndromes in animals. So some of them are zoonoses, but mostly they're transmitted to humans through insect transmission. So it's important then to, if you want to do surveillance for arboviruses, to consider all three of these aspects. So to look at both the reservoirs as well as sentinel animals that can develop disease. Human syndromic surveillance include febrile, neurological, and arthralgia symptoms, but also hemorrhagic fever signs. And then vector surveillance that includes ticks, calicoides, midges, mosquitoes, and sandflies. So arboviruses can be divided into two groups. The first would be the group where yellow fever, chikungunya, and Zika virus is located. These viruses are circulating between non-human primates and endemic mosquitoes in a sylvatic cycle. This is often found in Africa, but then you will get some spillover into the villages, and often here then it's picked up by Aedes aegypti or Aedes albopictus, and here you get a human cycle. So they don't need the animal host anymore. Humans become the host that can transmit it back to mosquitoes and onwards. And this is also then why these mosquitoes and these specific diseases can cause major outbreaks and be transmitted internationally and spread internationally. So these viruses are found mostly in central sub-Saharan Africa, with maybe the exception of chikungunya, that's also in southern Africa, but I must emphasize that it's very rare and that we haven't seen outbreaks in South Africa for many years. So mostly it is in the warmer areas of Central Africa. You can also then find these viruses that it correlates with the distribution of Aedes aegypti across the world. And then with the emergence of the Asian tiger mosquito, or Aedes albopictus, it actually then expanded range further into Europe and the Americas and so on, and Asia. But often in Africa, you will find smaller outbreaks that is associated with endemic sylvatic mosquitoes in the sylvatic cycle. And then only occasionally it will be picked up by Aedes aegypti, for example, and then cause these larger outbreaks. And this is then also, as I said, how it spread internationally. So this example is specifically for chikungunya, but it looks very much the same for yellow fever, dengue, and Zika. Okay, the second group of viruses are arboviruses that need an animal host as a reservoir to be able to transmit. So, for example, Rift Valley fever is transmitted between floodwater mosquitoes, so Aedes mosquitoes, and wildlife or livestock, and then they can cause big outbreaks here with many years intervals in between, but then also cause abortion in some animals, and often humans get infected here by contact with them or with the abortions. West Nile, Cimbus, and then some other viruses such as Mosquito again transmit between birds and Culex mosquitoes. So it gives these viruses the opportunity to spread very widely across the continent and also to other areas. It then only spills over into humans and certain sensitive animals such as horses and livestock during times of higher rainfall, which can be every year if there's a high rainfall area, or then increased bigger outbreaks during floods. These are, however, dead-end hosts, and it can't transmit back to humans. Back to the mosquitoes. So I'm going to use West Nile as the example because it's something that we work on in South Africa. But West Nile is very much underreported in Africa. So this map shows a study that we've done to look at areas where you actually have active reporting of West Nile cases. But as you can see, there's serological evidence that it actually exists in most of the continent. The virus has also spread internationally and is now the most widely found arbovirus associated with neurological signs. So in our lab, we've done a study where we use horses as sentinels to detect West Nile because they're very sensitive for neurological signs. And over a period of 10 years, we tested horses and we showed that over 90% have neurological signs, and they have a fatality rate of 35%. But we can detect West Nile during the rainy season almost every year in South Africa, and then in years where there was a higher rainfall in the season just before the outbreak, you'll get more cases or a larger outbreak. So about 7% of neurological cases in horses were associated with West Nile, and we can find it all over the country. And it correlates with seroprevalence of the veterinarians that's been sending us the cases as well. But still, cases in humans is very much underreported. So we've set up Sentinel Surveillance in a couple of hospitals in South Africa, in Gauteng, which is the area where Pretoria and Johannesburg is, and then in Mpumalanga, which is close to the Kruger Park. And we have a case definition for arboviruses of a fever with or without neurological signs, and then arthralgia and myalgia. And the study was done between January 2019 and December 2020. And we actually found that about 8.6% of hospitalized patients with fever and or neurological signs was due to West Nile virus. And you can see then about 64% of those patients actually had neurological signs. So this is much higher than has been reported in the country. And it's only really because we've done active surveillance to go and find these cases in hospitals that it would be detected. Most cases that's reported are milder cases that's submitted as a typical picture of arboviruses to the reference lab, but there's probably many cases missed in hospitals. We've also done vector surveillance in areas where we detected horse and other animal cases. So we have sentinel sites in the Gauteng area, as well as Mpumalanga and in northern KwaZulu-Natal. And so you can see this is what the farms look like, where we set up traps. We use CDC light traps and tent traps, and then also BG traps that's specific for Aedes mosquitoes. So over the years, you can see the most common mosquito that we actually get is Culex inventatus, which is a well-known West Nile vector, as well as Culex pipiens. And then, so when we screen with flavivirus PCR, we find West Nile in all the different areas that we've looked at, and the most common vectors being Culex inventatus and Culex pipiens, but there's also several others that were tested positive for West Nile. Okay, so to conclude, it's very important that vector-borne, or to notice that vector-borne diseases are endemic, important vector-borne diseases are endemic across Africa, but they remain very much neglected and underreported. Data is also lacking on the burden of disease. It's important to raise awareness with clinicians and veterinarians, as well as the public, in order to be able to detect these cases. And you have to practice a One Health approach for detection and prevention and control. It is possible to vaccinate animals to respiratory fever, for example, but most of the other viruses do not have vaccines. There's one for West Nile that will protect horses, but it doesn't influence the epidemiology because they are dead end hosts. It's only protecting the animals. In humans, it's only yellow fever really that currently have an active vaccine used in Africa. And it's very important for this reason to use the integrated vector control strategy in order to control arboviruses. Thank you very much. Thanks.
Thank you very much, Dr. Marietjie, for that excellent presentation. Participants, I encourage you to keep your questions coming, and we're hoping to have an engaging Q&A session with the experts on the panel. The next speaker is Dr. Vincent Obadan. He is a disease ecologist with over 15 years of research, applying One Health concept, focusing on understanding the dynamics and drivers of disease emergence and spread. As a veterinary researcher at the Kenyan Wildlife Service, he has experience working with intersectoral teams in response to zoonotic disease surveillance, prevention, and/or control. He's currently responsible for research, permitting, and compliance at the Wildlife Research and Training Institute, Kenya. Welcome, Dr. Vincent. You have 10 minutes for your presentation.
Good afternoon, everyone. Thank you. As you have heard, my name is Vincent Obanda, and my presentation will focus on data and sample sharing. Next, please. Next. Okay, thank you. No, just go back. I just wanted to say that One Health is a fantastic concept for approaching zoonotics. However, its implementation is facing a lot of challenges. It's common mostly for the teams or first responders to panic, and everybody runs to the field without really taking time or planning in advance. And so my presentation focuses that plan in advance, plan, and plan for what? You plan because zoonotic diseases are multisectoral and they are transboundary. And when you're dealing with multisectoral and transboundary, that means you're dealing with different sectors that have different policy guidelines, they have different regulations. And if you don't plan for that, you are going to have challenges ahead. Then also you plan because you are focusing on evidence-based intervention, meaning that you require meaningful data at the end. And so you need to plan that one in advance. So plan to have a data and sample management strategy well in advance. Next. So in your planning, plan to have designs that work. First, divided is that start with your scientific design, the scientific design component, which all researchers are aware of. What are your questions, your hypothesis, ethics? What are the type of your design? Is it cross-sectional or longitudinal? What are your data types and collection platforms? What are the sampling methods? Is it going to be random or non-random? What are your target species and populations? Understand your interface dynamics, because interfaces vary from one region to the other, one locality to the other. It's also important to consider data analysis well in advance. So it is important to engage statistician in the design and not post data collection. That always is another challenge, that people try to get a statistician to try to fix their data, yet the problem started well in advance before even they went to the field. Next. So another component that we have seen in One Health is a lack of planning for management design. This is very, very critical when you are planning for collaboration, data sharing, and sample sharing. So in management design is where you have structure for implementation. So the structure for implementation will ensure that you have a smooth way of data sharing and sample sharing, because they are subject to national and international laws. Within the national, you'll have intersectoral agencies. You have the wildlife sector, you have the livestock sector, you have the human sector, and you will find that they have differing requirements and policies on how they share data and how they share samples. And so if you don't plan for this, then you will hit a snag. They'll cause delay. Even your samples can lose their integrity because you are not prepared. Internationally, also sending samples across borders, across countries, has always been a challenge because the researchers rushed to the field and never planned for this. And so we propose that in your management design, plan to have a technical team. The technical team are the ones who are going to be responsible for the project activities, the outputs, sample and data handling. Then you need to have an advisory team. The advisory team are going to be involved in overseeing policies, administrative and legal requirements, so that they are working at that level that when you need this paperwork done, they are ready at the time that they are needed. Next. So under the technical team, mostly the technical team are dealing with the logistical planning to allow sample and data sharing across sectors. They need to plan to collect aliquots in the field. This will reduce freeze thawing because you want to share samples across sectors, across different labs. If you planned in the field, that means that samples that were going to lab A, lab B, lab C were already planned and aliquoted and coded in advance, so that they go to a specific repository. Plan to have a specific repository that repository will be able to ship the samples and handle interagency agreements that are required for sharing samples and data. Because it is easy to receive the samples, but if you didn't know that it will be difficult to remove samples from that institution, you will be frustrated. So it is good to be aware of that in advance. Plan for comparable analytical equipments and kits. You find that you have gone the animal sector, the livestock sector, the human sector, and you're trying to analyze, like my colleague has talked about West Nile virus. And then you find they're using different kits. Some kits are not even validated for the species that you are trying to use. And so it is important to think about that so that there will be ease of comparing the results. Then also plan for sample size estimates. Sample size in wildlife may be subject to costs because in some countries, each sample is costed. And if you didn't plan and you are coming with the sample size of 384, the cost, you will not be able to even get that 384. Secondly, maybe the species is endangered and it is protected. So you need to be aware of that in advance. And also sampling, the estimates should allow for comparability of the results. Plan for concurrence in sampling period, data collection platforms, the metadata types that will be collected, coding, the inclusion and exclusion criteria. We have found that, yes, you are a team of human, wildlife, and the domestic and the environmental teams, the ecological teams. But then you find the teams are going at their own times. And so what they are going to find, especially if it is a prevalence study, a cross-sectional study, the dynamics of time and space may cause variation. And so it is important that all these are planned in advance, that the teams can go together and the causes of variation can be comparable across the results. Next. So the advisory team of under the management, in the human and the animal sectors differ in policies and infrastructures, as I was said. And the need for sharing samples and data require legal agreements. And here, the most common agreement that will cover all the sectors is material transfer agreement, prior informed consent, mostly applicable to the wildlife sector, mutually agreed terms are applicable to the wildlife sector, data transfer or use agreements are applicable to all sectors. The prior informed consent and the mutually agreed terms are based on the Nagoya Protocol Treaty that some countries in Africa have ratified, and they are part of their domestic laws. And if you're intending to work between countries, it is important to understand and be aware that these procedures, these agreements take time. They need also involvement of the legal teams of your institutions. And so if you are aware, you are able to plan in advance to allow smooth sample movement and data sharing. Next. So I will also want to clarify that agreements are not MOUs. MOUs are usually gentlemen agreements on how you are going to work together. But agreements are enforceable, legal binding contracts. And so they take a lot of time. They take a lot of due diligence by the legal teams. And so it is important that the response teams are aware of this. Next. So prior informed consent is basically a contract where the resource, the person who is going to use the resources being sought, seeks to explain in a manner that the person who is going to provide, the resource provider, will understand who is receiving the samples, for what, why, what is the purpose of these samples, where is it going to be used, what are the quantities, and what are the potential benefits to that country when you collect these resources from that country. Secondly, mutually agreed terms. This just describes how to implement the PIC. The data transfer agreements is also a formal contract that spells out the why, the purpose, why, security, confidentiality, the costs, the protection of the data, and all that. Then the material transfer.
Dr. Vincent, sorry to interrupt. Please, if you could kindly wrap up so that we can move to the next speaker. Thank you.
Thank you. Next. Let me wind up at that moment, and thank you very much.
Thank you very much, Dr. Vincent. I'm sure that a lot of questions will be coming in at the Q&A. So some of these things you would have loved to share, you can always feel free to talk about it.
Thank you.
Thanks very much. I have my last speaker for this session, Dr. Leanne Francesca Thomas. She's a veterinarian and an epidemiologist with strong interest in economics of zoonotic diseases. Apologies, just the screen's moving around. Strong interest in economics of zoonotic disease control within a One Health framework. She's originally from the north coast of Cornwall in the UK and studied veterinary medicine at St. George University in West Indies. She has gone on to do a master's research in Uganda in conjunction with the Makerere University, and move up to Kenya in 2010 to pursue a PhD within the Zoonotic and Emerging Disease Research Group. A PhD focused on the epidemiology of T. solium cysticercosis in humans and porcine populations in Western Kenya. Leanne currently leads the theme on the neglected zoonotic diseases within the BMZ-funded One Health Center in Africa at ILRI, and holds a One Health Fellowship as well. Over to you, Dr. Leanne, for your presentation.
Thank you, Dr. Alimi, and I'm very sorry I tried to start setting up my my presentation before you had finished talking, so I apologize for that. So I'd firstly like to thank you for chairing this session, and to thank the organizers for giving me the opportunity to talk today. Let me just start again and hope that I can manage to get it going this time. So I am going to speak to you today about the economics of One Health. Okay, sorry, one moment. This is me trying to be preemptive and get everything going and just managed to muck it up. Dr. Alimi, can you let me know? Hopefully everyone can see the proper presentation slides now.
Lovely, we can see it.
I'm so sorry. Okay.
No worries.
In the short time that I have left, we are going to quickly look at why we should be interested as One Health practitioners in gathering economic data. What do we need to do to generate that data? And what, if any, data currently exists for the benefits of One Health in surveillance? So why should we care? So economics is the comparative analysis of alternative courses of action in terms of both their costs and their consequences. And we use the discipline of economics to help us make decisions about the use of scarce resources as we search for optimality. Now, as One Health practitioners, most of us probably are working within inherently resource constraint areas, and we certainly have lots of competing interests. I mean, by the nature of our work, we are working in all of these different sectors, each of which has their different priorities in ways that they can invest their resources. So here is just a small generic figure indicating where we could use economic data in the design and rollout of our interventions. So first of all, we need to use it in our agenda setting. So here we need to get data such as the burden of disease, both in terms of health and economic burden, which can help us prioritize which issues is it that we want to actually deal with. We then need to design our interventions, and we may use economic data again here to model that before we roll it out to see, is this going to be of benefit to society? We want to collect data on economics as we roll out our interventions, in this case surveillance, so that as we go through, we can evaluate how well our intervention is performing, make any adjustments and go forward. So what do we aim to do with an integrated One Health surveillance and response system? We want to reduce the avoidable losses to humans, animals, and the environment. And that might be of a particular disease or of our response to that disease. So let's just take an example of foot and mouth. We want to prevent outbreaks because our response to that disease is to stop trade, and we therefore want to avoid those losses. And of course, we're well aware that the losses that we're thinking about here can go across each of these sectors, and they can be direct. So this may be the mortality or morbidity of animals or humans, and therefore their lost productivity, or it may be somewhat more indirect. So say here, the loss of traction for these cattle, or loss of manure inputs to crop production. We can also think of difficult to quantify burdens, such as social stigma due to having a particular disease or grief, and those which are becoming more quantified, but still are somewhat difficult to get a handle on, such as the loss of ecosystem services that might happen if there's environmental degradation. So what could we do to try and think about how well our surveillance is performing in terms of avoiding those losses? And there are two evaluation techniques in economics that you could think of. One is the cost benefit analysis, which is thinking about the costs of surveillance and the benefits you derive both in monetary units, or cost effectiveness analysis, which is probably more often used in health economics because of the sort of ethical issue around putting a value to human life. And this is where we're thinking about the benefits or the effectiveness of our surveillance in terms of non-monetary units. And many of you may have come across the DALI. This is one of the metrics that has been used to quantify human health in terms of morbidity and mortality in one metric, and it's the disability adjusted life year. So here we're looking at how many dollars do we need to spend to save a DALI. So let's give an example of some data that's been collected that might allow you to start looking at these costs and benefits in surveillance. And I hope you will have all just been listening to Dr. Venter's presentation, so we don't need to go into what West Nile virus is. But in Italy, this virus was detected, and they took her suggestion and they instigated surveillance in the horses, that sentinel species, but also in wild birds and mosquitoes. And this surveillance system was found when they costed it out and they had a look at what was going on. What happened was when you had the detection of virus in any of those domains, it would trigger screening of blood donors in a much more targeted way than the current national system did. And the analysis of this integrated surveillance suggested that it was cost saving and that it had the ability to protect human health, potentially preventing between 2 and 18 cases of West Nile virus, which could have become a neuroinvasive disease over the period of analysis. Now, these authors didn't go as far as presenting a cost-benefit ratio, but the data was really there to start being able to. Okay, right. Sorry. The other way we could get our economic benefits from One Health surveillance is about when we're thinking about cost sharing or cost saving from joint response. Now, in order to do this well and actually gain savings from it, we need to listen to Dr. Abanda's advice and plan. This will not happen if this is not set up in advance. So we're thinking here about how can we utilize potentially community health volunteers or community health, animal health workers to become community disease reporters across species. How do we share laboratory facilities or data management systems, or potentially travel to the field in the same vehicle? And here there are economic benefits to be gained. Now, if we want to sort of think about that, maybe without the sort of impact on health that we're having, we can think about just cost minimization analysis. So assuming that we will come to the same benefits, we're going to have equivalence and consequence, we may be able to look at our different surveillance options and response options and rank them based on cost. But either way, whichever of those evaluation techniques we're going to use, we really need to get those gritty cost data. And the CDC has created a standardized tool that's going to be allow people to actually start collecting that data within outbreak situations. And there is a paper that's published, and all the links will be at the end of the presentation. And I really urge those of you in the audience who are involved in surveillance and response to start thinking about using this sort of tool so we can gather the data we need to do the analysis. But still within the sort of field of economics, but a little more difficult to put numbers to, is that there are also intangible benefits from doing surveillance across sectors. And these may not necessarily fall out as health or economic monetary impacts. This might just be about building social capital or intellectual capital from working together. There is a lot we can gain from meeting each other, discussing cases, pushing forward our practice, and really advancing the way that we work as society. And then also difficult to quantify is that as we generate this data, this is the data we will use to advocate for investment. Now that may be very it may be long-term, it may be difficult to quantify immediately, but nonetheless is a really valuable aspect. And this paper from Switzerland, which looked at Campylobacter surveillance, really sort of demonstrates that intangible aspect. And they showed that over the period of analysis, they did not find a sort of cost effectiveness of this particular surveillance system, yet they really felt that it built intellectual capacity amongst the stakeholders and was instrumental in the policy change, policy shift that was seen in Switzerland, whereby Campylobacter flocks became only able to sell into frozen meat sales. So there was a real sort of shift of policy, and this was instrumental in that. We still have many challenges in terms of pushing One Health economics. And this was mentioned a couple of times. I think Dr. Venter mentioned it. We really don't have very much in terms of burden data. And what we even more so don't have is burden data, which is quantified in a standardized metric. So I mentioned the DALI in human health economics. This has become very well adopted, and there are very standardized methodologies in which you can use to calculate this. There has been some work on trying to do this for zoonoses, but it's still really in its infancy in terms of uptake. We lack standardized models and thresholds that we can use to establish cost effectiveness. And of course, we have that perennial challenge that the costs and the benefits accrued across different sectors. And we really need to look at the ways that we can find cost sharing mechanisms that reflect that. And we are lacking real world studies. And so this was very much exemplified by this 2017 paper that concluded really that we had very little empirical data demonstrating the economic impact of One Health. And so we need this economic data. You guys are in the field, so I implore you as the audience, we need to get collecting this data so we can convince decision makers to invest. And with that, I'll thank my colleagues and my funders. And there's a lot of further reading because we couldn't fit it in this small presentation. So I'll refer you to the slides. Thank you very much.
Thank you so much, Dr. Thomas. I was just about to tell you to wrap up, but you really did put it that nicely. And so to all participants, we have the Q&A function where we'll be taking some of your questions from. All of our experts have been able to unpack quite interesting thematic areas looking at how to incorporate vector surveillance, things like planning, as well as considerations for legal agreement around data. I mean, we always want to say we want to ensure the easy flow of data across sectors, but there needs to be considerations for legal agreement and data safety and privacy. Most importantly, in terms of how do we then use the data to advocate for financing around domestic financing, as well as external funders. So all of my panelists have been able to put all of this very nicely, and I'm hoping that you have a number of questions for them to answer. We'll start off with Dr. Obada. One of the key things around One Health that many of our organizations, and I'm sure you also advocate for, is collaboration. But one of the things that we need to focus on as a continent is not just across sectors, but also across countries. So I think this participant is curious to know how your institution or how your expertise or your group of experts collaborate with other African countries on zoonotic disease material transfer, and what are the prospects for sort of shared resources when you think about regional laboratories and things like that. Over to you, Dr. Vada.
Thank you very much for the question. Quickly, some of the agreements are proposed by the international treaties, and African countries have been increasingly becoming party to those treaties, and they are beginning to enforce. And so across Africa, we are beginning to talk as one voice. This is to ensure that at least there's accountability and also benefits for the countries, because it's not just about zoonotics, but it's about also benefits that come from those genetic resources. In terms of capacity building across African countries, at the moment, we find that there's a lot of disconnect. There are some countries that prefer to only use material transfer agreements, but they are not enforcing other forms of agreements because their countries prefer not to engage in that line. And so you'll find that disconnect. And so it's important to be aware before actually engage in that country. Yeah.
Thank you, Dr. Vincent. Dr. Lien, this question is around the One Health cost benefit analysis in specific animal health related problem. This participant has put a spotlight on rabies, particularly because rabies would usually affect domestic pets and not necessarily affecting farm animals, which of course you're able to tie in the cost, benefits and things like that. So how do we analyze sort of or count the benefits for improving surveillance or interventions around controlling diseases like rabies? Over to you.
Thanks, Dr. Alimi. That's a really great question. And this is where we need to really sort of think about expanding our One Health economic framework. So the traditional way in which rabies economic evaluations has been done would be looking at the cases of the human cases potentially averted. So we could model our projections of cases. We can translate those either into DALYs, i.e. the sort of morbidity and mortality suffered, or look at the cost of illness. So it may be that, of course, you've got a bite case and you're getting PEP. So you're looking at the cost of that prophylaxis rather than obviously cost of illness and death. But in terms of the actual benefit to dogs, that's been much less often studied, though there was a study in, oh my gosh, I'm going to get this wrong. It was Barbara Hassler, and I can't remember if it was the Philippines, but they did look at the societal benefit of rabies vaccination. And they considered in that a much wider framework where they were looking at sort of peace of mind, but also animal welfare. Now, animal welfare is maybe quite difficult to quantify, especially as the questioner said, when it's not livestock where you can easily put a sort of a dollar value, well, relatively easily put a dollar value on productivity losses and things. So we do need to start thinking about ways that we can quantify these otherwise intangible benefits, such as animal welfare. There is movements to be able to do that. So in the same way as people value ecosystem services through a willingness to pay approach, we consider doing more of these willingness to pay studies, so we actually try and get people's perception of what animal welfare is worth in a monetary value, and that can start helping us expand our framework and do more cost effectiveness analysis. And it's really important. I mean, we really need more One Health metrics, not just human and animal health, but taking these wider things, ecosystem services, animal welfare, so we can look at this from a societal value. Sorry, I'll stop.
Lovely. I can see that the organizers have already let me know how many more minutes we've got, but I feel like there's some questions that participants would definitely benefit from. Dr. Venter, I'm coming back to you. I know that you've already put a typed answer, but I think this question is particularly important. And this participant is curious to know integrated vector management strategies. For the longest time in Southern Africa, as well as Central and Western Africa, has really been focused on malaria. There are opportunities for us to learn, and how can we then transfer the knowledge and the experience gained over decades and decades of vector management strategies for mosquitoes looking at malaria? How can we then transfer to other zoonotic zoonoses vectors? Over to you.
Thanks for that question. So yes, obviously the integrated malaria or vector control is important. We already have that knowledge and you can use some of that. But you must remember many of these viruses are transmitted by Aedes and Culex mosquitoes rather than Anopheles, and their breeding patterns may be different, and also their feeding patterns is different. And so it's also important then to include animals in this vector control strategy. So I think that understanding the epidemiology around these diseases and then bringing that into the vector control system is important. So involvement of veterinarians as well, to understand that it's actually the animal aspect here that can spread the diseases, and then also environmentalists to ensure that we don't contaminate the environment further by doing this. But personal protection for people is very important, and that we also use for malaria. So using repellents on people and then also on animals is really important to control some of these diseases.
Fantastic. Thank you very much. Just to ensure that we're able to really enjoy the next few sessions, I will urge the panelists and experts to continue answering some of the questions on the Q&A chat function. I encourage the participants, while our experts are here, to at least put some of your questions. I believe that they will be able to type answers and give you feedback. On that note, I would really like to thank all three of you for joining me on this session. It's been particularly enlightening and interesting, and I'm hoping the participants really enjoyed the session. Over to you, Dr. Dak.